Hi everyone, greetings from the first day of Endobridge. Welcome to Endocast. I'm Dr. Ceyda Dinçer. Here I'm together with Professor Dr. Djuro Macut from University of Belgrade. Hi, Mr. Macut. Thank you for accepting our invitation.
Hello, good afternoon.
Today, an interesting insulinoma case was presented in neuroendocrine tumor case session. Insulinoma is a rare neuroendocrine tumor, and the workup of the patient can be a challenging issue for clinicians. First, I would like to ask, how do we approach a patient presenting with complaints of hypoglycemia, and how we diagnose insulinoma?
Yeah, this is very complicated situation because we have lots of patients that are coming with some hypoglycemia symptoms. Actually, they have something like sweating, some dizziness, some not clear minds, and they said that they actually had such episodes irrespectively of the day or related to the food consumption. So in these cases, we have to ask the patient to deliver blood test. The best one is with the glucometer, if they have this at home or in the surrounding, or to go to the lab and then to deliver the glucose whenever they experience such an episode. And then if there is the low level of glucose, of blood glucose, which is standardly less than 2.2 millimoles per liter, someone could be investigated further for the existence of hyperinsulinemic condition. And the insulinoma is actually one of the most important ones, and this is the hallmark of the hypoglycemia syndrome in endocrinology. So after the analysis of the blood glucose in the vein, at that very moment, if the patient, when the patient is suffering a problem, we have to perform the long hypoglycemia deprivation, food deprivation test of 72 hours, 3-day actually starving test, which we have to do in the hospital. And then we are following the patient for 3 days and looking if there will be any episode of low glucose correlated to the clinical picture. If we found such a situation, then we are proceeding with the next stage of diagnosis, which is the imaging techniques like CT scans or magnetic resonance image. We can sometimes use the octreoscan scan, which is the nuclear medicine diagnostic procedure, but the best one is the endoscopic ultrasound. That is definitely the best method for the analysis of the lesions of that kind within the pancreas.
How should we proceed in patients whose endogenous hyperinsulinemia was detected, but the lesion could not be localized with imaging techniques?
If we do not succeed with any of those methods, we have to use the provocative testing by using the infusions of calcium, and then we are looking the response of insulin from the different veins. And by determination from which part of the pancreas is the highest amount of insulin, then we are deciding to operate a specific part of the pancreas. So the first procedure or the first therapy to the patient, when you ask me, for the definitive treatment of the patient should be surgery of the pancreas. But before that, we have to offer the patient the condition of normal glycemia, or the normal glucose level, by giving the drugs. We can give glucose, but the best one will be to give the diazoxide, which is the inhibitor of insulin secretion from pancreas. And with those drugs, patients could actually achieve a normal glucose and be prepared for the surgical intervention. So we can make resections. Nowadays, we have laparoscopic surgeries, And only with very experienced surgeons, we can take out enucleate the tumor if it is small and not complicated. Otherwise, we have to perform the more aggressive surgeries, which are the partial pancreatectomies or the whole pancreatectomy, which is the Whipple procedure. So depending on the localization of the tumor, the volume of the tumor, and other indices, we are deciding about the treatment. So surgery should be the first line definitive therapy.
Okay, thank you. What is the limitations in the use of medical treatment options in these patients?
We have many limitations because some patients are not responding to those drugs for the inhibition of secretion, and we do not have many other options. Actually, we can use the analogs of somatostatin, but they are not such specific and efficient in the treatment. And there are some attempts to use the radionuclide therapies for those patients, and there are no other options. So actually, the best option is, and the first line therapy should be operation or surgical treatment. In all other conditions, we can use dioxazide so for the maintenance of the normal glucose for the prolonged period. But those therapies have other side effects, retention of fluid, etc. So they can actually change the volume of the patient, and they can actually deteriorate the heart function and produce other complications. So we must be very much observed when we are giving diazoxide with those patients.
Okay, thank you very much, Mr. Macut, for appreciating your valuable time with us.
Thank you for the invitation.